The 2022 National HIV Testing and Treatment Guidelines update clinical standards to achieve the 95 to 95 targets by 2026. All HIV testing services must strictly adhere to the 5 Cs: consent, confidentiality, counseling, correct results, and connection to care. For individuals older than 18 months, diagnosis requires a 3-test algorithm using Assay 1, Assay 2, and Assay 3. The Treat All policy mandates ART initiation for all adults living with HIV, regardless of WHO clinical stage or CD4 count. Rapid ART initiation is defined as starting treatment within 7 days of a confirmed HIV diagnosis. The preferred first-line regimen for adults and adolescents is a fixed-dose combination of TDF-3, TC, and DTG. DTG is prioritized due to its rapid viral suppression and a high genetic barrier to the development of resistance mutations. The standard dose for DTG is 50 milligrams once daily for adults, and for children weighing at least 20 kilograms. Routine viral load monitoring is the gold standard for monitoring, performed at 6 months and 12 months after starting ART. Viral suppression is successfully achieved when the results show fewer than 50 copies per milliliter. Low-level viremia is defined as detectable viral load results between 50 and 1,000 copies per milliliter. Virological failure is confirmed by 2 consecutive viral load measurements, exceeding 1,000 copies per milliliter within a 3-month interval. Monitoring TDF toxicity requires regular assessment of serum creatinine and the estimated glomerular filtration rate. Do not initiate TDF if the estimated glomerular filtration rate is below 60 milliliters per minute or in cases of renal failure. Screen all patients for TB at every visit using the 4-symptom screen: current cough, fever, weight loss, and night sweats. In patients with active TB disease, RT should be initiated within the first 2 weeks of starting anti-tuberculosis treatment. For TB co-infection using rifampicin, the DTG dose must be increased to 50 milligrams twice daily. Advanced HIV disease is defined as a CD4 count below 200 cells per cubic millimeter or WHO clinical stage 3 or 4. Adults with a CD4 count at or below 100 cells per cubic millimeter must be screened for cryptococcal antigen. Cryptococcal meningitis induction requires 1 week of amphotericin B at 10 milligram per kilogram and flucitosine at 100 milligrams per kilogram. The consolidation phase for cryptococcus involves fluconazole at 800 milligrams daily for 8 weeks following induction. Oral pre-exposure prophylaxis is recommended for HIV-negative individuals at substantial risk, using TDF and FTC or 3TC. Post-exposure prophylaxis requires a 28-day course of TDF, 3, TC, and DTG initiated within 72 hours of exposure. Pregnant and breastfeeding women must initiate the TDF, 3, TC, and DTG regimen regardless of CD4 count to eliminate vertical transmission. High-risk HIV-exposed infants should receive dual prophylaxis with NVP and AZT for a duration of 12 weeks. Children weighing 20 kilograms should be transitioned to DTG-based regimens to reduce pill burden and preserve NRTI sequencing.